Okay, so just to welcome Sharon and Anniek, thank you for joining us, and over to you.
Okay, so thank you very much for giving us this platform. It's very nice to be invited. So Sharon and I we wrote this paper, EU Health Solidarity in Times of Crisis, explaining public preferences for EU risk pooling for medicines. And this came out of a broader research into public preferences that was done on solidarity. So basically, there was a large survey that was done also on fiscal solidarity in the EU, and part of that, and we also at the same time asked people about solidarity with regards to access to pandemic medicines. So I don't know who has the clicker. Yeah. So so in EU, across the EU, there's some shifting solidarities in health policy in general. There's to some extent in some member states a more focus on individual health, and so solidarity is one of these aspects within the states that always needs upkeep, and that is also continuously changing the way that we feel about that. And so at the same time, there is the EU integration in health policy and the development of the European Union as a whole, and so that then poses some questions also for research. So what we did is we outlined, and this is in a different paper, we did that a little bit more extensively, but in this paper we did that too. So we outlined kind of, so what do we mean by EU health what do we mean by EU health solidarity? What does that concept mean? We come up with these very simple understanding of EU health solidarity. In any case, it involves risk pooling and redistribution. And this concept has two different implications. On the one hand, it's with the within state implications. So how solidary do we feel? And of course, also how does that translate to the laws that we have? How solidary do we feel with our fellow citizens within the member states? And then how solidary do we feel? How does solidarity play out between states? And of course, also there is with citizens. So how solidary do I feel with someone from Germany or Italy? And how does that solidarity then play out in politics and public policy with regards to access to medicines? What we see in the EU is there's, of course, an inequality in the availability. So we looked at this in the context of medicines, particularly in the context of pandemic medicines. And that is also because the emergency situation usually evokes a particular type of solidarity within people, or it has some, and that was based on previous research as well. So now, when it comes to the to medicines as one of the sites where solidarity is of importance, is on the one hand in the EU there's an inequality in the availability of medicines, and there are shortages of medicine in the EU. And from my own previous research, I had looked at the joint procurement for medicines from in the swine flu pandemic. Also important, maybe important to note that we started this research before there was any idea that there would be a COVID or corona virus outbreak. So it really didn't start out as this being something that would be specifically important for COVID. It's not a COVID research. So I had done research into the SARS outbreak, and I had looked at joint procurement of pandemic medicines and what happened at the time, and the troublesome situation around solidarity at the time, some member states buying all the medicines, other member states having no access to medicines. And I thought that that was an important site of where there could be an improvement of EU policy, but also an important site of solidarity. And then maybe, and that is also what sort of prompted to do this survey. So we outlined some key policy dimensions that we wanted to ask people about. So we've done a survey on how solidary do you feel about this, and particularly, and we tried to make it as concrete as possible with regards to what policies would people actually prefer. And so we asked them about sort of these key policy dimensions. So first we asked them about scope. So what medicines do you think should be subject to EU joint procurement? And do you think that all medicines should be subject to joint procurement, like contraceptives and I don't know, all kinds of medicines, or just pandemic medicines? And then we asked them about allocation. So how do you think that if there was a common stockpile of medicines, how should access to this stockpile be regulated? Do you feel like the contribution should it be contribution based? So however much your member state paid into it, that's how much that member state should get for their population? Or do you think it should be based on need? So if the health situation is worse in one country, they should have earlier access or preferred access. And then we talked about, we asked citizens about decision making. So who should then decide on the use of medicines? Should it be an EU agency, or should it be national agencies and experts? So, you know, who should decide on how these medicines are used, etc. And this brought us to this. So, just bringing us to the main research question: what rationales drive public preferences for alternative EU joint procurement programs for medicines? So, in asking citizens about what policies they would prefer, and we also wanted to know, what drives those preferences? Is it, for instance, pro versus anti-EU integration? So is it about the EU, or is it more about redistribution, about economic left-right ideology? Or would it be the emergency that matters? And of course, at the time that we fielded this survey, there wasn't any COVID threat, but we specifically, because the research came from this with SARS in the background, I knew that, or we had this hypothesis that and also based on previous research, that an emergency situation would matter for people on whether or not they would feel solidary or not, because emergencies are more limited in time and shorter and more extreme, etc. And but for this research, when we fielded the survey, that is when COVID started happening, and so there were some had some sleepless nights thinking about what that would do with our results. But in the end, we also soon realized that the corona outbreak was such a big deal. People would still have it in mind in 5 years, and so we might as well go ahead with the research at that time. So that is why the emergency or the COVID-19 threats in this case was another aspect of understanding what the rationale is behind public preferences for a particular type of policies and laws in accessing medicines. And I now hand over to Sharon.
Okay, so let me put this research paper into the broader literature on public opinion towards health solidarity. We have seen that this research track is really at the very early stages of development. Most studies on health solidarity are focusing on national policies. So there is only a very limited number of studies that research the public opinion towards EU health solidarity. And these studies look at it from very different approaches. So we have seen that some studies focus on the basic principle of EU responsibility over healthcare, whereas others focus on solidarity between solidarity for the provision of medical supplies to other countries, such as face masks, and yet other studies focus exclusively on financial support for healthcare programs or on so-called corona bonds. So at this moment, there's only very limited empirical evidence on whether there's a new conflict on the issue of EU health solidarity emerging on this topic. And with this paper, we contribute to this wider research agenda by focusing on the case of centralized EU purchasing powers for medicines. So we analyzed the data from a conjoint experiment that was set up with our colleagues Roel Beetsma, Brian Burgoon, Francesco Nicoli, and Frank van den Broeke. The survey was fielded in March 2020. As Anniek mentioned, it was at the very early beginning of the COVID-19 outbreak, and the survey was run in 5 countries, including Germany, the Netherlands, France, Italy, and Spain. So we have some southern and some northern countries, but it was not, the survey was designed beforehand, so we did not take into account the impact of COVID. But we are actually very happy with our selection of countries, because at the time of the survey, these countries were hit to different extents by the coronavirus. So the survey was fielded by Ipsos, by their online panels, and we used quota. These are quota sampling, which means that they are more representative based on age, gender, education, occupation, and region of the respondents. In total, we have information of more than 8,000 respondents who completed the questionnaire. And because each respondent was asked to evaluate 3 different pairs of policy packages, we have more than 51,000 observations. So the unit of analysis is not the respondent, but the choice for a certain policy package. We analyzed the data based on the standard statistical approach for analyzing conjoint experiments. So what we are explaining is whether a policy package is chosen over another package. And these were, the design of the policy packages were randomly composed, so that we have much more information on how citizens prefer, or towards the preferences, the relative preferences towards alternative policy packages. So these packages differed according to the 3 policy ingredients that we are interested in. As Anniek mentioned, these are the scope of risk pooling, the allocation principle for the medicines, and the decision-making over the use of the medicines within countries. In our survey, we also have information about individual characteristics, which allows us to test how different groups of people respond towards alternative packages. So by combining the experimental part with the observational data, we are able to test whether some people are more sensitive towards a specific policy design feature than others. So conjoint experiments are really a great tool for causal inference, because they allow us to test the relative impact of each of these policy design features together in one survey, which is not possible with a standard survey. But on the other hand, conjoints have also been criticized for being very complex, and that respondents cannot process all this information, or that they do not pay much attention. And therefore, we included an attention check in the survey at the very end. And the respondents who did not pass this test were excluded from analysis to exclude further bias in our results. So each respondent was first presented a short introduction framing about what EU joint procurement is. So it was mentioned that European governments had agreed to purchase together medicines for infectious diseases, and that such a program has some financial benefits, and that it also has a possibility to organize a common stockpile, but that this could be organized in very different ways. And then they were asked 3 times, which one of the 2 following options for this European program do you prefer most? So here you can see that for each pair of policy package, these packages differ precisely on the 3 dimensions that we are interested in. So some, for the first dimension of the scope, some of the packages had only a limited scope, whereas others included all medicines where there was a financial advantage of purchasing them together. Then for the second dimension, some of the packages proposed that there would be fixed shares in the common stockpile, so each country can only use its own share in the stockpile, but it can do so whenever it wants. And other packages would propose the principle or a mechanism of need-based solidarities, with countries having priority access to the stockpile in the case of an emergency. And then for the final dimension of decision-making, some packages propose that there would be an European agency deciding on the use of the medicines in the countries, and other packages propose that this would be left to the national experts or national agencies. So we developed 3 hypotheses. The first hypothesis is that people who are more Eurosceptic, so who oppose the idea of EU membership and who oppose European integration, that they would find packages more attractive if they have only a limited scope of risk pooling, that if they have they do not tolerate solidarity for the distribution, so they are based on contributions and do not tolerate priority access, and also for packages that propose national decision-making, because these policies are, they limit the extent to which there is a further integration at the European level, and Eurosceptic people can be expected to prefer policies, or at least keep the process of integration within limits, and these policy features are then preferred over their alternatives, which would require a more deeper integration in the EU. Our second hypothesis is that people with more egalitarian values are more likely to support EU joint procurement if there's a wider scope of medicines and if packages tolerate need-based solidarity, for the reason that these policies are more efficient in reducing inequality, and they also contribute to more social justice in health policies in Europe. And then we had a final hypothesis about the impact of COVID-19 and how it is perceived by respondents. Here we expected that people who feel more threatened about the impact or the consequences of COVID for their country would be more likely to support packages that have a wider scope and that also tolerate need-based solidarity across countries, because these policies are more efficient in mitigating risks that are posed by health crises. So these are the first results for the dimension of the scope. So these graphs represent the marginal effects of policy packages that have a wider scope compared to those that have only a limited scope for respondents at different values of their Euroscepticism, egalitarianism, and perceived threat. And we observe that, in fact, there's very little contestation among publics over the scope of medicines. only for egalitarianism we find a significant effect with people who have more egalitarian values being more in favor of packages that have a wider scope than those who have anti-egalitarian values or less egalitarian values. But the effect is rather small, so we could say that the scope of medicines is not very salient in the public opinion. We have found more interesting or more strong results with respect to how the allocation principle affects the public opinion. And there are two interesting observations here. The first one is that all three rationales seem to play a role. So EU joint procurement for medicines is more supported if there is need-based solidarity, and this is true for everyone, because you can see that all the effects are above the red horizontal line of 0. So the effect is positive even among those who are hard Eurosceptics. Such a mechanism of need-based solidarity still increases the likelihood that they are in favor of joint procurement, which is quite a surprising observation. The second observation here is that the effect somewhat differs across these three individual characteristics. So not everyone responds similarly to the design when it comes to allocation. People who are more pro-EU minded, who have stronger egalitarian values, and those who have more concerns about COVID, these are in particularly more in favor of policies that propose need-based solidarity. So they are more sensitive towards this dimension. And then finally, with respect to the decision-making level, as we expected, we found that this matters, but to a different, in a different way for Eurosceptics and pro-EU-minded people. For Eurosceptics, they can be mobilized in favor of joint procurement if the policy proposes that decision-making would belong to national agencies. Then these people become more in favor of EU joint procurement. But the opposite is true for people who are in fact pro-EU and who want more integration, because among this group, is really the majority of the respondents, they prefer packages where there would be an EU agency deciding on the use of medicines. And then for the people who have no clear vision on or have neutral positions towards European integration, they are in fact insensitive towards this issue of decision-making level, meaning that it doesn't matter whether national or EU agencies decide on the use of medicines, because it doesn't impact their choice for a particular policy. As a second part of this research, Anniek and I were also interested in whether these different rationales would operate similarly across the countries in our survey. So we have done some additional analysis to figure this out. In general, we have found that the impact of Euroscepticism and egalitarianism is very similar across countries. We find a consistent pattern there. But we do find some interesting country differences when it comes to the impact of COVID worries. These effects are rather small, but still interesting to see. A first difference that deviates from the general pattern is found in Germany. We observe that people, so just to clarify, the blue dots are respondents who have less than average or who have concerns about COVID that are weaker than the average in their country. So they are not really concerned. The red dots is the policy preference of the group that is more than average concerned about COVID. So we see in Germany that the group of respondents that doesn't feel threatened by COVID or that is not really concerned, they tend to prefer policies with a smaller or a not more narrow scope of medicines. And A potential explanation for this could be that compared to the other countries in the survey, Germany is in a relatively stronger bargaining position with the pharmaceutical companies, and that therefore EU joint procurement for a wide range of policies does not really seem appealing to Germans if they do not even feel threatened by a health crisis. So this could be a potential explanation for this difference. And then a second country difference we find in Spain. Here we see that people who are more concerned about COVID prefer need-based solidarity, whereas this is not so much the case in other countries. There the difference is much smaller or even insignificant. And we think that this could be related to the fact that at the moment of the survey, there was a very high medical need in Spain, and that the respondents already anticipated on what need-based solidarity would mean for their country. So they took into account the medical needs in the other countries. And based on this, they could expect, or they expected that Spain would actually benefit from a need-based solidarity. So it's a kind of self-interest reasoning that might explain this. And then finally, in Italy, we also observe that the impact of COVID-19 is a bit different when it comes to the decision-making level. Here we see that people who are very much concerned prefer policies that are decided on at the national level, whereas this is not the case in the other countries. And this could be related to the fact that Italy was the first country that was hit very severely by the crisis, and the initial response of the other countries and of the European Commission was rather slow in supporting Italy, and that therefore those who had strong concerns, they show more protectionist behavior when it comes to shifting further competences to the EU, and that therefore they prefer national decision making. So to conclude, whether European populations support EU joint procurement for medicines is an important question for health governance in Europe. And this conjoint experiment tells us a lot about the sensitivities in the public over the design of these policies. So to answer our research question, what are the rationales that drive citizens' policy preferences, we can conclude that of all three factors, it is mainly Euroscepticism that explains preferences for certain policy designs. But we also find that there are considerations of social justice and fairness that do play a role in citizens' preferences, although the impact of ideology was much less than we expected. And for COVID-19, we could say that this is not really a dominant driver or explanation for why citizens prefer certain policy packages over other ones, as the impact was very small and also strongly depending on the context. And then with respect to the policy implications, I want to give the floor back to Anniek.
Yeah, so I think what was important, that an important aspect that we found for some of the discussions that we have been having around the changing role of the EU in the field of health generally, particularly spurred on by COVID, is, for instance, and particularly also when we talk about joint procurement, is that it seems that at least there would be that the nature of the medicines that are jointly procured by the EU is not a major factor for citizens, for public support. So that could imply that as a policy implication, other medicines where there are shortages, where there is a lack of access, the EU could potentially play a more important role in also the purchasing of medicines, which is, of course, from a more general sort of first step into more EU health solidarity. It would be a big step for the field as a whole. And so, thank you very much. for your attention. And we look forward to questions. Yes.
Excellent. Thank you, Anniek and